let me just start. I was doing a talk yesterday, and the point that I want to make really is that I think infant mortality, more than anything else that we deal with, is a marker for our entire social system. It's a marker for how we care for our fellow citizens. I was looking at some data on poverty, and it struck me very clearly that all of our work around health care is in many ways dwarfed by the work we need to do around poverty and the work we need to do around education. And for example, there's a study, and it's fairly old now, it's from 1998, that shows that if you compare individuals with incomes of less than $10,000 versus individuals with incomes of over $30,000, that at every age those with less than 10,000 have a 3.22 times higher death rate. If you control for age, race, sex, behavior, tobacco, physical inactivity, smoking, all of the behaviors, the death rate based on poverty alone is still 2.66 times higher. So that 76% of the excess death is due to poverty, not due to behavior. And then when you begin looking at some other things, for example, if you looked at the state of Virginia, and if you made the mortality rates the same throughout Virginia as the mortality rates of its wealthiest counties, you reduce mortality by 25% over a 15-year period just by increasing income. That if you look at who doesn't die, 75% of the savings are in people with a high school education or less. When you begin to look at racial disparities, what you find is most of the racial disparities are tied to income and education. When you look at the effect of education, 4 years of college is worth 4 years of longer survival for women and 7 years of longer survival for men. Which gets back to what the World Health Organization said so many years ago: the best predictor of the health of a population is the income of the population. The best predictor of the income of the population is the educational status of the mother and the family. So if we only have $1 to spend, and my health care colleagues always hate this, my education colleagues love it. If you only have $1 to spend it on education, not health. Health will follow. Education doesn't follow health. And that becomes important because, to me, when we talk about infant mortality, we're not just talking about health care. We're talking about changing a social system. And to a large extent, what we do with our public health interventions are important, but we need to understand we're working at the margins. We are trying to save those few children that we can save. We aren't fixing a lot of the fundamental problems. But having said that, let me thank you for the opportunity of being here, the opportunity of speaking. I think what we are trying to do is extraordinarily important. In 2012, there were 58,000 births in Alabama. Now, one of the very interesting things that I've observed is that the economy is a great predictor of birth rate. If the economy is good, birth rates go up. If the economy is bad, birth rates go down. For example, prior to the Great Recession, we were at 62,000 live births. Today we're at 58,000 births. So when, for example, we see declines in teen pregnancy, I am certain that I want to take credit for that because I'm surely going to get blamed if it goes in the other direction. But the reality is some of it are things that are beyond our control. They are tied to the economy. 2012 was not a good year for Alabama. Our infant mortality rate went up to 8.9 per thousand live births. We grow further and further disparate from the national average. In fact, if you actually look at our number of infant deaths, it's the greatest number of infant deaths it's one of the two worst years in the last 4. And in fact, we go back to 2003 with the same number of infant deaths. That to me is a really, really troubling regression. Well, you know, I was tempted when folks came to me with this as a campaign slogan to put a T-shirt on the baby. But I saw no positives that could come out of that, because I was going to put an Ole Miss T-shirt on him, and I figured that probably wouldn't sell very well. So anyway, we'll just let the child play with the football. We believe there are some places we can make a real difference. Now, it's not going to drop our infant mortality rate to below the national average, but these are winnable battles and they're savable children. There are things we can do about sleep. There are things we can do about tobacco, breastfeeding, and convenient deliveries. Obviously, this is tied to the COIN initiative. And so we want to launch a public awareness campaign to promote safe sleep, smoking cessation, breastfeeding, and waiting 39 weeks to deliver. The reasons are very simple. We now know clearly that unsafe sleep environments, whether that is co-sleeping, whether that's sleeping on the stomach, that socioeconomic factors, life stressors, smoking, and preterm birth all contribute to infant mortality. Likewise, we know that breastfeeding decreases infant mortality. To me, this was extraordinarily interesting. When we looked at our infant deaths, about a third of them occur after the first month of life. Of all infant deaths, 16% are somehow sleeping related. Either they are co-sleeping, they are SIDS, they are accidental suffocation, strangulation. So this creates an opportunity. Making sure that baby has his or her own space becomes a real opportunity for intervention. And it may not save all 16.8%, it won't, because we don't understand all the causes of SIDS. But it will save some children. So one of the things that we put in our budget request for 2015, I have to remember what year it is, 2015, and I've committed some departmental resources, is we want to expand the Cribs for Kids program statewide to reduce sleep-related deaths. And the reason's simple. We know very, very clearly that infants that sleep in a safety-approved cribs on their back and sleep alone have a significantly decreased risk of dying from either sudden unexplained infant death or from SIDS. So we can save some babies with that initiative. Maternal smoking. You and I both know these are underestimates of the prevalence of tobacco consumption during pregnancy. After all, no one voluntarily admits that they did bad things when they're pregnant. Just like none of us have ever been caught speeding. So what you can safely assume is that 10.7% is probably a minimum estimate. It's twice that high or more. Well, of all of the factors that I've been able to identify through multivariate models, this one factor, tobacco consumption during pregnancy, is the one that has the greatest attributable risk for higher infant mortality rates. And it's about 50%. Tobacco consumption during, or even self-confessed tobacco consumption during pregnancy, increases your infant mortality rate by about 50%. So that is a real opportunity. Well, I have been providing for women at risk of pregnancy or pregnant. I've been providing through the health department 2 weeks of nicotine replacement therapy. And I was really proud of myself. Except I now understand that I've been spitting in the wind and making no difference. So again, we've sought funding for and have committed dollars in this fiscal year to expand that from 2 weeks to, I think, 10 weeks of nicotine replacement therapy. Since the data shows it takes 6 to 12 weeks to effectively assist in reducing tobacco consumption, we're going to make an investment to try to get women who are smoking or who may become pregnant to get them off tobacco with the goal of reducing that infant mortality rate. Births less than 37 weeks. 14.9% of our births now occur at less than 37 weeks gestation. Now, what does that mean? That truly means that about 85% or so are occurring after 37 weeks, as you would expect. But here's, to me, really the most amazing statistic, and really, for me at least, as a non-OBGYN, I had always sort of assumed that 38 weeks was as good as 40 weeks because they're all term babies. Well, just like everything else in medicine, there are shades of difference. They're not all term babies. We define them as term, but they're not all the same. Look at the difference in the infant mortality rate for a 37-week baby, 7.4 per 1,000 live births, compared to even a 39-week baby, 2.1 per 1,000 live births. Look at a 36-week. That's 1 out of every 100 babies dying. Compare that to a 40-weeker. That's 1 out of every 500 babies dying. So pushing deliveries to 39 and 40 weeks will save babies' lives. I talked to my colleagues in Texas. When they went statewide just with the signature of a pen and Medicaid stopped paying for early term elective deliveries. They also got Blue Cross to do the same thing in Texas. They closed NICUs in Texas because the demand was no longer there. Babies survived. So we've committed to work with the hospitals, the OB community, the family practice community, to by the end of this year, to have eliminated elective early deliveries in Alabama. We'd like to do that as we've done a lot of things, whether it was some of our newborn screening initiatives or hearing initiatives. We want to start in a voluntary manner. We'll ultimately migrate to implementing rules. We want to work not only with Medicaid, we want to work with Blue Cross. We want to change the culture. I think all of us understand why somebody wants to deliver with the OB that they're familiar with. But I also think every mom and dad, when they understand that convenience of the convenience of delivering at 37 weeks is offset by the risk to the child if you simply go to 40 weeks or 39 weeks, they'll be willing to delay that delivery. Obviously, we're not talking about not delivering babies who need to be delivered early. We're talking only about those elective deliveries. And this is one that hasn't changed for a long, long time. 50% of the births in Alabama are unintended. They're either unintended because mama never wanted to become pregnant or because she wanted to become pregnant but become pregnant later. We know that the infant mortality rate for unintended pregnancies is significantly higher. I think we've done a lot of good work around expanding family planning access, about women receiving long-term contraceptives in family planning visits. We've made a difference. But unfortunately, there are a significant number of women who miss their first postpartum visit. If you miss the first postpartum visit, and if you're sexually active, we have a name for that. It's called you're pregnant again. We know that the interpregnancy period is correlated with infant mortality. The closer the births are together, the worse the infant mortality rate. So one of the things we want to do, working with the hospitals and again the OB community, the provider community, is to ensure that long-acting reversible contraceptives are available in hospital and that women can get them inserted if they choose to before they go home, so that when they miss that first postpartum visit and they're sexually active, they're not unintentional parents again. We want to work to alleviate the barriers for Medicaid women to obtain replacement LARCs. There's work to be done, but this gives us an opportunity to drive down that unintended pregnancy rate. If we drive down that unintended pregnancy rate, we will obviously drive down our infant mortality rate. So, our goal is that together we can reduce the risk of unplanned pregnancies. We can improve the health of the newborns and mothers of Alabama by facilitating healthy spacing, and of course, will reduce infant mortality. As a parent, I cannot imagine the trauma, the stress, and the sadness associating with losing a child. Whether that's a child who may be 10, 15, 18, or a child that you lose in the first year of life after so much planning, anticipation, or excitement. That causes enormous emotional stress. Children who are born with long-term health complications cause enormous financial stress, both on the family and on society. And this gives us an opportunity to make a difference. Together, by reducing deaths attributable to improper sleeping practices, by preventing unintended pregnancies, by working to expand breastfeeding, we can reduce the cost of health care for children and for adults with special health care needs, and we can end up having a healthier state. So it's my privilege to announce that we're committed. We've committed dollars in the 2014 budget. We've asked for, I think it's about $4 million in the 2015 budget to address infant mortality. Now that's not enough, but it's an investment. If we're able over the next several years to get those dollars and to see the benefits, then I think we're positioned to go ask for additional dollars to expand our activities into some other things we want to do to reduce infant mortality. So thank you so very, very much for taking your time to be here today. Thank you for giving me this opportunity to participate in the conference and to announce this new commitment on the department's part to drop the infant mortality rate and to never again be first in the country in infant mortality. Thank you very, very much.